Good evening. Great to be with you all today virtually to talk about future directions in theranostics and nuclear medicine. Today, I'm going to focus more on an overview regarding care delivery rather than talking too much about the science, because that's already been well covered by very prominent figures in the field, such as Drs. Weber, Dr. Clay, and Drs. Hope. So we're going to talk, again, take a different approach to what changes need to be done within the field to really take advantage of this opportunity that's being presented to us with regards to diagnostics and therapies. So traditionally, when we talk about a cancer program, we really focus on three pillars or three core specialties: med-onc, surg-onc, and rad-onc. And obviously in GU malignancies, the surg-onc piece is focused on urology. I would make the argument that in today's environment, when it comes to prostate malignancies, really nuclear medicine needs to be the fourth pillar, not only for the diagnostics, but for the upcoming increase in utilization of radiopharmaceuticals. And in order to do that, I think we really need to adjust how we approach various aspects of care, which includes the clinical care, research, and education. And that's kind of what I'm going to talk about today. So clinically, I think there's no question in everyone's mind that it really is PSMA or bust when it comes to diagnostics. And this slide comes from Dr. Michael Hoffman from Peter MacCallum in Australia from the PRO-PSMA study. This was a randomized phase 3 study that compared PSMA PET-CT versus conventional CT and bone scans. And as you can see, there was superior accuracy with PSMA PET-CT, greater impact on treatment, and fewer uncertain results. So this study really validates in a prospective randomized trial the higher performance of PSMA PET-CT versus our conventional imaging. So there's no question this is where we're headed. This trial, the therapy trial from Dr. Michael Hoffman as well, was first presented at ASCO this year. And this was a trial that compared lutetium-177 PSMA versus cabazitaxel. So it was actual direct comparison to another therapy in the castration-resistant space. And what you see here is that the PSA response of greater than equal to 50% was much better in the PSMA arm of 66% versus those patients who received cabazitaxel with a 37% response rate. On top of this, the adverse effects and the tolerability of PSMA was also better than cabazitaxel. So you could see that we are clearly moving into this space of radiopharmaceuticals as well. In the US, we are eagerly awaiting the data from the VISION trial, which it's no longer Endocyte, it's Advanced Accelerated Applications, which is owned by Novartis. So this registrational trial will hopefully be the trial that leads to the approval of these PSMA targeted therapies in the United States. And we're hoping in 2021, perhaps at ASCO, to see the data that'll hopefully lead to the FDA approval of this drug, which will be game changing for the US. And the PSMA diagnostics and the therapeutics will really allow the United States to catch up with Europe, South America, and Australia when it comes to these technologies. So when we think about how care is changing, I think we really need to focus on how we deliver care. And I think nuclear medicine clinics are something that we need to bolster. It is currently being performed in multiple sites across the country, but that is not enough. We need patient-facing clinics where nuclear medicine physicians, nuclear medicine radiologists can actually meet patients, perform consults, and evaluate patients in order to get the right therapies afterwards. Because now we will have lutetium-177 PSMA. We also have radium. And these different therapies, we need to be able to understand and best recommend when to use these therapies in our patients. That'll also lead to the increase of E&M coding, which I'm sure people have heard more about this these days, and given the fact that they're thinking about increasing reimbursement for E&M coding. But more than just the reimbursement, I think this is good care, and this is good for radiology, this is good for nuclear medicine. So it's something that I think we need to embrace and expand. Multidisciplinary care is obviously something that is growing, and it's a core part of oncology delivery. And nuclear medicine and radiology, typically when we participate in these tumor boards, it's mostly from the diagnostic perspective. We present the cases, we present what we see on the imaging, but I think that needs to go to another level. And now we actually have the ability to participate in the diagnostic discussions and the therapeutic discussions. So it's important for us to be able to be familiar with the trial data that's been published or new trials in the pipeline and actually contribute meaningfully on both ends to those discussions. And then a next level involvement involves active participation by the specialty in multidisciplinary clinics. It would be wonderful to be able to have a patient come in for a med-onc visit, but the medical oncologist then feels that one of the radiopharmaceuticals is a consideration. Then a nuclear medicine physician, it would be wonderful on that same day, that same afternoon, to be able to see that patient in clinic, assess them, determine eligibility and appropriateness, and then move on to that therapy as soon as possible. You could see how this would lead for a much more patient-friendly experience that is invaluable in today's healthcare delivery models. So part two, I want to focus on research, which is an absolutely critical part of how we continue to advance this field and take ownership of this field. So this slide comes from Michael Hoffman as well. This was from the therapy trial. And I think patient selection, this idea of using imaging to select the patients appropriately is something that we need to dive deeper into and really understand better. And in this trial, Dr. Hoffman actually very thoughtfully used PSMA and FDG to select the patients that would be most appropriate to undergo the PSMA targeted therapy. I think certain questions are still unanswered with regards to how we best do this. How do we quantify perhaps how much activity there is with PSMA or FDG and really find the best patients to undergo these therapies? So again, is it in the future, is it going to be PSMA only to determine eligibility? Could it be FDG only? Could it be PSMA plus FDG? Or maybe there's no imaging involved. And I remember listening to Dr. Scott Tagawa talk about this. Apparently, there's a trial being designed right now that is going to use no imaging and just go straight to these therapies, which perhaps in a hormone sensitive setting, that would make a lot of sense because the expression of PSMA in these patients is quite high, probably greater than 95 or close to 100%. So again, something to be considered and something that we need to learn more about. Treatment response is another area. It's I think it can be done, but the bigger question is, should it be done? Is there a real value in using this expensive technology to determine response? What if PSA could be just as good? Again, I hope that's not true, and I don't think that'll be true, but I think we need to own that and really figure out the answers to these questions. So when it comes to research, obviously, I think we need to bolster our involvement in basic science research, continue promoting translational research, and bolstering our clinical research as well. And all this is going to require investment. But if we focus on clinical trials, I think this is where we have the greatest opportunity. The idea of a nuclear medicine physician as principal investigator on a clinical trial has come. It can be done. And we have leaders in the field, such as the Michael Hoffmans, the Tom Hopes, the Jeremy Clays, the Wolfgang Webers, that have shown this can be done and it can actually really be good for the trials themselves. So this is something we hope to increase in the future. Team-based research is obviously a critical part of this, and it's something that is going to become even more important as we move forward. And we need more mentors. We need mentors within the specialty of nuclear medicine. We need mentors in the field of radiology. And we also need mentors outside of our field to help us navigate these waters. And it's great to see a lot of these trials come to fruition and be successful. And they are multidisciplinary. And these are the things that we need to continue to promote. But we need to meet our partners where they are today. The last part I want to talk about is education. There's no question there's so much opportunity when it comes to education. And if we focus on medical students, it's really about getting medical students aware and interested about a potential career in nuclear radiology, nuclear medicine. And I think this could actually resonate very well with medical students because it's a fascinating field. It's just that the exposure to these medical students is very minimal. And that's been shown in various studies. Resident education is important as well. We know traditionally radiology residents have not chosen nuclear radiology or nuclear medicine for their fellowships, and that's a problem. I think today when it comes to workforce planning, this is absolutely critical. It's a dynamic field. It's a field where you could have a robust career in diagnostics and therapeutics. You could still maintain that patient interaction that many of us still want. So this is something I think we need to spend even more attention on and find ways to increase that workforce pipeline. Fellows, how we train fellows is going to change as well. Fellows will have to be trained more in the clinical aspects and the therapeutic aspects of the specialty as opposed to just the diagnostics. And interspecialty, it's really the responsibility falls on us to educate our colleagues about the value and the appropriateness of these technologies in their patients. Overall, if we do this well, nuclear medicine will benefit, radiology will benefit, and more importantly, the patients will benefit from this higher level care. So, in summary, this is a new era for nuclear medicine. We really need to take advantage of this opportunity to create nuclear medicine clinics that are patient facing. We need to own the research, and radiology needs to own the research. Nuclear medicine needs to own the research. So, I encourage the leaders of the RSNA, the SNMMI, and other organizations to continue investing in this research because it does make a difference. And finally, we need education reform, which is a good thing. This is a new era, and I think we need to meet that with a new model for education. So clearly, it's a time for change, and it's going to require very strong leadership. Leadership not only from the chair, but leadership from heads of cancer centers, heads of medical schools, heads of hospitals, but also leadership at every level. On the front lines, it requires leadership to take the initiative to make some of these changes. The shift to E&M billing, the shift to patient clinics, I know that's not something that we're all used to, but it requires someone to take the initiative to create these and really change how things are being done. So I thank you all for your attention and happy to take questions.